thank you, and if there's some other questions, feel free to grab me. Dr. Laura Pace is coming up, and she's so thank you, Laura.
Okay, so I am a gastroenterologist, and I see a number of complex patients with neuroimmunologic diseases. And so I'm going to talk about, I think, the evaluation that needs to be done in this patient population that is often not undertaken by my colleagues. These are my disclosures. I have funding from the National Institutes of Health and from Dysautonomia International. I'm just going to start with an overview of the gastrointestinal tract, which is really quite basic, but just to make sure that we're all on the same page and kind of thinking about this complex problem with the same framework. So the human gastrointestinal tract is very long. It has different physiological properties throughout its length. And so if we think about what the stomach does, it's primarily food bolus processing. There's very little absorption that takes place in the stomach. And then once we get into the small intestine, this is really where the bulk of the work is done within the gastrointestinal tract. And so this is where you have your macromolecular breakdown, you have nutrient absorption and water absorption occurring here. Once you get into the colon, you're more dealing with water storage, with waste storage, water absorption, and basically concentration of stool waiting to have timed evacuation. What I'm not going to talk about is, just will draw your attention to on the left side of the slide, is the microbial concentrations throughout the length of the gastrointestinal tract. And you can see that there are order of magnitude changes throughout the length. But Dr. James Hump will talk about this in more detail with his talk. Then if we look at the layers of the gastrointestinal tract, there's a lot of small blood vessels here, very small nerve fibers and neuroimmune cells, and all of this has to have an integrated function in order for your gastrointestinal tract to work appropriately. And to go back to sort of the question earlier about leaky gut, if you have dysregulation in any of these systems, you have the potential to have changes in gastrointestinal permeability. If we look at this slide from a paper published in 2017, it's showing you very nicely the intimate association with these small nerve fibers that are penetrating to the, is there a pointer? Okay, sorry, I don't know if this will work. But you have the lumen here. No, it doesn't show up. So the lumen's at the top of the slide, so that's inside basically the tube of the gastrointestinal tract, and you have this very thick mucin layer, and that actually helps with barrier function. And this is where you'll have some microbes who will actually be interacting with the epithelial layer, which are the purple cells. And then you have basically small blood vessels, you have lymphatics, and you have nerve fibers that are penetrating all of these layers. And then this slide I like to show everyone because this is the innervation of the gastrointestinal tract. This is from the autonomic nervous system. And if we look at sort of all the areas that are innervated by the autonomic nervous system, if you have a disorder that affects your autonomic nervous system, you're going to have a lot of problems with your gastrointestinal tract, from motility, from secretion, from digestion, all sorts of things. And so when a patient comes into clinic and they're telling me about all these symptoms, and it's, starts to make me think, is this a disorder of the autonomic nervous system? And so one of the things that was very prevalent throughout my training was learning about functional disorders, and most of my colleagues talk about these. And so it irks me a little bit, and I'll sort of explain why. So typically we see a patient that has a number of systemic complaints. And so whenever in the field of gastroenterology we are presented with these patients, the go-to diagnosis is a functional disorder. And it's actually not helpful to patients. What physicians mean when they're diagnosing a person with a functional disorder is that it's a disorder where the symptoms do not have an identifiable structure or biochemical basis. Problem is that they haven't even done any evaluation yet, so how can they be satisfied by giving a label for something that they don't understand? That wasn't the intention of these functional diagnoses. They were first created and defined by the Rome Foundation starting in the 1980s. And so they've published several iterations of this, and they do talk about an evaluation that should be undertaken prior to giving these diagnoses. But it's often not completely followed. They've also changed sort of what their definition of a functional disorder is. And so it started with basically absence of organic disease. So they tried to classify them into groups so that they could actually start to study them and understand some of these symptom complexes a little bit better. And then they said it was stress-related or psychiatric, and so it really wasn't their issue, and these patients were dismissed from the gastroenterology clinic. And then they actually got the ability to look at gastrointestinal motility because new technologies had evolved. And so then they found out, well, lo and behold, some of these patients who were coming in with these complaints actually had gastrointestinal motility disorders. And so then they went more broadly to gastrointestinal dysfunction because we developed a few more tests and could identify a few more disease processes. And then most recently, they've come up with disorders of gut-brain interactions, and this is sort of what they say. Functional gastrointestinal disorders are disturbances of neurogastroenterology and gut-brain interactions. And so I think they need to go a little bit further than that and include neuroimmunologic disorders, and I'll talk about that in a little detail. So I'm going to start with a case. So this is a case that presented to me as functional nausea and vomiting. So this is a young woman who had just aged out of being followed in a pediatric gastroenterology clinic. And so she was coming over to establish care with me as an adult gastroenterologist. And so she had a diagnosis of neurofibromatosis type 1 and interstitial lung disease and had been on immune modulators. And so she had had daily nausea and vomiting since childhood, and her and her mom were super animated when they tell the story, but she couldn't ride on the school bus without vomiting. And so they figured that if they didn't feed her breakfast before she rode on the school bus, she could get to school without vomiting on the school bus, and then they fed her breakfast when she got to school, and she vomited when she was at school, but everybody agreed that that was easier to deal with, and so that's what they did. But then, by the time she came to see me, she had been having 2 years of what she called drop attacks. And it was just the cutest thing describing this, that she would just basically feel as though the entire world was spinning. She would lay on the floor, kind of face down, kind of holding on for dear life. And so someone from her family would have to scoop her up and take her to the emergency room. She would get some IV fluids and some anti-nausea medications, and the episode would subside. What the heck is this? So everybody had just attributed this to her diagnosis of functional nausea and vomiting, even though this is a dramatic change in her chronic symptoms. And so I'm sitting there listening to the story, and I'm just like, the first thing that I'm going to order is an MRI of your brain because something is not right. And lo and behold, she ended up with a diagnosis of limbic encephalitis. So this is an autoimmune process. We changed her immune modulators, and the drop attacks went away. Her actually chronic nausea and vomiting that she had since childhood also improved dramatically. So this is just sort of a brief overview of autoimmune encephalitis, but what's interesting really is the top point, is that these are more common than your viral encephalitides, and yet we're actually not testing for them. So then we're not diagnosing them, and then we're not treating them. So really, the point in sharing this case with you is this was not a case of functional nausea and vomiting. And so this really could have been fatal if we had not caught it. And so I think this is why I try to impress upon my colleagues, we need to be aware of what the neurologic system is doing and the immune system is doing. So now I'm going to switch gears a little bit and talk about some of the modalities we have available within the realm of gastroenterology to kind of get after how we can get better diagnoses for some of these individuals. So this is a slide that describes the different modalities we have for gastrointestinal motility testing. And I sort of broke it down into sort of two big categories. One are transit time studies, so super common to get nuclear medicine gastric emptying studies done. But all this tells you about what the stomach is doing is whether it's emptying solid food within an expected amount of time. It doesn't tell you anything else about the function of the stomach, which is actually extremely complex, so that it can actually do the macromolecular breakdown that we require. There are other scintigraphic-based testings where you can actually look at transit time in the small intestine and transit time in the colon, but again, it's not giving you any additional information, which can be super important. And then there are the manometric-based studies, which I'll give you a couple of examples in detail. There are two that are available at most centers. So one is esophageal manometry, and that's where we look at the function of the esophagus, and then the other is anorectal manometry, where we look at the function of the pelvic floor. Only at very highly specialized centers can you get ANTRODUODENAL-JEJUNAL manometry, so you're looking at basically the stomach into the proximal small intestine, and colonic manometry done. So this is not available to just anybody. You have to go to a very specialized center and have someone who's actually willing to do this type of study. And then at the bottom, I'm actually going to talk about a new device that's actually available and should be more accessible outside of these highly specialized centers. I'm going to give two examples where I talk about esophageal manometry and ANTRODUODENAL-JEJUNAL manometry, just to make a couple of points. This is what a typical readout of esophageal manometry looks like. So you have time at the bottom. You have the colors represent pressure, and so the more red the color or purple, this is a higher pressure zone. And so what this represents is 2 swallows, and so you can see a change over time that you see basically the pressure going down the esophagus, because here's a diagram of the esophagus. And so what is really important to notice here is that it's not pressurizing the entire esophagus at the same time. You have this coordination where you have the top part of the esophagus squeezing, the section below it relaxing to accommodate the food bolus, and it does this very rapidly but in an organized fashion so that the food bolus goes in the direction we expect it to, which is towards the stomach. So there are a lot of esophageal disorders, but I'm only going to mention 2 of the major disorders. There's achalasia, and I'll give you some examples of that. And then minor disorders, we don't really know what to do with these. We don't know what the natural history is. But in my patient population, which includes a lot of people with autonomic nervous system disorders, they have really high rates of these minor disorders of esophageal motility. And what I know just anecdotally from following them long term is that some of their symptoms associated with the feeling that they're not able to swallow appropriately actually wax and wane, as do the rest of their symptoms that I attribute to autonomic dysfunction. So this is just, again, now this is 3 panels showing you the 3 types of achalasia. The one, type 1, has essentially no contraction within the esophageal body. So these people have a very difficult time actually moving a food bolus from the mouth to the stomach. In type 2, you basically have pan pressurization, but it's actually a lower pressure throughout. But again, they don't have that nice coordination to move the food bolus in the direction that we would expect. And then type 3, they have very high pressures in the esophageal body, but they essentially have that high pressure contraction occur throughout the esophagus, so occurring at the same time. And then they have very high pressures at the gastroesophageal junction, so that is not opening to allow the food bolus to go into the stomach. And so we've actually known for a long time that many of these disorders, like achalasia, are actually immune problems. So people have done studies, and they've been publishing this for years, looking at autoantibodies, concomitant autoimmune diseases, and yet what do we do to treat these disorders? Surgery. And then the people that are treating these patients surgically are always surprised, well, it comes back, or it actually doesn't treat it appropriately. So there was a really nice study that was actually just published this year. It actually looked at the loss of these interstitial cells of Cajal. So these are your cells within the mind's plexus that are necessary to sort of coordinate muscle contractions. And so what you can see from this panel, that there's actually loss of these cells in the individuals with achalasia compared to the controls, which are on the left side of the panel. And so this really suggests that this is like a degenerative process that maybe if we caught earlier and treated appropriately, we could have potentially prevented or reversed. Another thing is that they actually looked at mast cell infiltration. And so on the right side of the panels, you can see the cells stained in brown with tryptase, that they're showing that there's an increase in mast cells that are infiltrating the tissue. And so is this a mast cell disorder, and could we have treated this differently? So really, are these immune-mediated disorders, and should we be treating this in a different way? And I would say absolutely yes, but we have to be creative in how we look for it. I think this could be antibody-mediated based on the literature that's available. It can also be infiltrative, and I gave you the example of the mast cell case, but there's also cases that have shown that there is eosinophilic infiltration or lymphocytes. There's some data to suggest that there's also changes in the cytokine profiles, and whether that's a primary driver of this process or secondary is not clear at this time, but it's, we're starting to think about sort of these inflammatory cascades. And then neurodegenerative, and whether that is primary or secondary is not clear. We need more research in this area so that we can understand the natural history of these processes. So now I'm going to show you ANTRODUODENAL-JEJUNAL manometry. And so this is a catheter that has to be placed endoscopically. And so what you can see on the right panel is the catheter that is basically coursing out through the antrum of the stomach, across the pylorus, in through the duodenum, and then going all the way down into the jejunum. And what this catheter has is a series of solid-state sensors on it that actually can detect pressure. And what you see on the panel on the left is with the, I hope you can see the arrows there, but that's a more proximal sensor that's detecting a pressure wave. And then in the line below it, you can see then that pressure wave tracking. And what you're seeing is that over time, you're seeing the pressure wave go from a proximal sensor to a more distal sensor. And so that's actually moving the food bolus in the direction that is appropriate and what we actually want it to be doing. So this is a normal study here. And the reason that this is considered the gold standard for looking at gastrointestinal motility disorders is because people have always said, and this is exactly what I learned in training, that this technology can differentiate between a neuropathic disorder and a myopathic disorder. So something that's mediated by the nervous system or something that's mediated by sort of like a muscle disorder. But someone went and finally tested that hypothesis. And so this was published in 2018, and I was so excited when this paper comes out, and I use it in just about every talk because I think it's awesome that they finally did this. So this is what they would describe as a neuropathic pattern on ANTRODUODENAL-JEJUNAL manometry. And the reason they call it a neuropathic pattern is because you're getting adequate intraluminal contractions. So those pressure sensors are detecting pressure. But what they're doing, just like in the achalasia, is that they're detecting pressure simultaneously. So you basically have your small intestine over long segments simultaneously contracting. Well, that's not going to move the food bolus in the direction that we actually want it to go into. So this ends up being like a motility disorder. So it's a signal of something that's wrong. When they actually looked at the pathology of this, it actually was a myopathic disorder. And then this is a myopathic pattern. And the reason they say this is because the contractions are actually occurring appropriately and consecutively in the different sensors, but the pressure is really much lower than would be expected. So they think this is sort of like a muscle strength problem. And this also was not. So they went and did full thickness biopsies of the small intestine in some of these individuals who had very severe gastrointestinal motility disorders. And they looked at, these are just two different stains that are staining the myenteric plexus. So that's the nerve bundles that run between the two muscle layers in the gastrointestinal tract. And what they showed in the controls is that you should really have this robust staining, so those kind of brown blobs there. But in the cases, you don't. So you're having loss of these myenteric plexus neurons. And so what's driving this can't tell you, but this can tell you that there's clearly a problem. They also, and this is again just to go back to mast cells, they actually used a tryptase stain in some of these individuals and were able to show that it stains brown, that they had, and then the myenteric plexus is not stained, but it's kind of a swirly pattern in the middle, is that you can see that there's an infiltration of more mast cells in the cases compared to the controls. So again, now you have like an infiltrative process. They also have examples, again, of eosinophilic infiltration and lymphocytic infiltration. So this is sort of immune dysfunction that's probably contributing to the patterns that we're seeing on manometry. And so really, it does tell us that we need to consider full thickness biopsies of the small intestine in some of these individuals who have severe gastrointestinal motility disorders. We probably should consider it earlier in their disease course because it may actually change the way we treat them. And it may, but we don't know, allow for a reversal of some of the injury if we can deal with the immune process early on. It also calls into question the current gold standard for diagnosing gastrointestinal motility disorders and begs the question, is there a modality that is more easily accessible, so not in these highly specialized centers, that others could be using? And I'm going to argue yes, and I'll talk to you about the SmartPill wireless motility capsule. But first, I'm going to give you a case example of how we use this clinically and how this can really help us. So this is a 43-year-old male with a remote history of Burkitt's lymphoma, and he actually had originally seen my colleague, Dr. Clardy, who you'll hear from later today. And so he had presented to her with worsening fatigue and paresthesias, and he also had early satiety, anorexia, and weight loss. And she didn't think too much of that initially because she was really concerned that he maybe had a recurrent malignant process. He had had elevated protein in his CSF, and he had some low positive antibodies to some of his muscle receptors. And so because of these findings, she actually pursued getting a PET CT, which actually looked at basically really active areas within the body. And you can see, and I'm sorry I don't have a pointer, but the more red areas are the areas where there's a significant more activity within the muscle tissue than is normal. What was interesting is that he was also incidentally found to have very significant food retention within the stomach on this study. And this was really abnormal because you have to fast a really long time for these studies because you don't want the digestion process to be giving you a false signal. And so at this point, Dr. Clardy referred this man to come see me. And so we use this technology that I've been telling you about, the SmartPill, to try and figure out what was going on in this gastrointestinal tract. And so I'll walk you through this slide. It's a little bit busy, but so time is on the bottom, and then the green line is pH. And so you can see that it drops very low. That indicates you're in the stomach, and then it has a dramatic rise, and that's when it empties from the stomach and goes into the small intestine. And then you have another drop when it gets into the colon, and then it spends the rest of its time in the colon. The blue is temperature. That helps me understand when the person swallowed the capsule and then when it exited the body. And then red are pressure measurements. So the higher the peak of that pressure spike, the higher the pressure in that area. And so just a couple things. He had, even though you can't appreciate it on this because it's all scaled to the same size, his stomach was 16 hours and 38 minutes for emptying. And normal is in that 4 to 5 range. So this is really delayed. So this explains why there was so much food seen in his stomach on his PET CT, why he was having these symptoms of anorexia. And then his small intestine was also prolonged at 7 hours, where we think less than 6 is in that normal range. And then his colon was very prolonged of 94 hours, and we think less than 58 is probably in that normal range. So he's delayed in all regions. And so what we did, well actually what Dr. Clardy did, was she treated his myositis with steroids and rituximab, and so many of his gastrointestinal symptoms got better. So he comes back and sees me, he's gained weight, he is eating normally again, and so we repeated the SmartPill to see what had actually happened. And again, because of the scaling issues, but his stomach went down to actually closer to the range of actually rapid gastric emptying, but he wasn't having any symptoms from it, so we don't do anything about that. He felt great, he was eating. His small intestinal time normalized, his colonic transit time normalized, and I didn't do anything. We treated his autoimmune disease, and this got better. This is a very powerful tool, I think, because it can be used in the outpatient setting, in the sense that the patient comes in, they swallow the capsule, they wear a recorder for up to 5 days. This does not require a specialized center to do. So I think we can gather a lot more information. Can we hold questions till the end? So what I'm seeing in my patient population, where I see a lot of patients with neurologic disorders, is I'm seeing high rates of regional and global delays. And so many of my patients will come to me with a nuclear medicine gastric emptying study that's either positive or negative. Most of the time in these individuals, when they're super symptomatic, their small intestine is incredibly delayed, as is their colon. I think this is a really powerful finding because this changes the way we treat these symptoms. And I think that this could potentially replace, in some instances, the ANTRODUODENAL-JEJUNAL manometry, because all I think we need to know is that there's a significant abnormality, and then we need to figure out what's causing it, because the ANTRODUODENAL-JEJUNAL manometry actually can't, as they've previously thought, differentiate between a neuropathic and a myopathic disorder. And so I think we need to be considering full thickness small intestinal biopsies in a subset of this population when appropriate. Now I'm just going to finish up with another set of cases that I see commonly. So this is people who are presenting with abdominal pain and they're ending up with a systemic dysautonomia. And many of these people have been managed in pediatric gastroenterology clinics for many years before they come to see me, and their initial complaint when going back and talking to them always is abdominal pain. So this is an 18-year-old female, so that's when I saw her. She had originally presented, I think at age 13, with abdominal pain. And I always wrote this in my notes because I thought it was so funny and I didn't know how to interpret it, but rocks in her stomach, that's what she described, and that's what she started telling her parents at age 13 that she had. By the time I saw her, she was having orthostatic tachycardia syndrome, she had these allergic symptoms, but she had already had this surgery that they thought was contributing to her abdominal pain, so to treat median arcuate ligament syndrome. And so median arcuate ligament syndrome in the classic thinking is thought to be a vascular problem, where the median arcuate ligament, which is really just a component of the diaphragm, comes down and presses on a particular artery that feeds the gastrointestinal tract, and they have a bunch of other names for it. I was told in training that these people always present with abdominal pain after eating. That's the only thing that they'll have no other symptoms. And then they have to have evidence somehow on some imaging modality that they have compression of that celiac artery. And this is what it looks like. I'm sorry I don't have a pointer, but the aorta is the big solid line here. It's on both sides. This is during inspiration. You can see the celiac artery is the top artery that's coming off at the top up there. That the ligament is sitting right on top of it, and then with the expiration, when the diaphragm descends, it comes down and includes the origin of the celiac artery, so right here. And so that's why they think this is a vascular problem. So she actually had surgery at age 15 to correct this problem, and yet by the time I saw her 3 years later, she was worse. She had symptoms that suggest an autonomic nervous system disorder. She had now had allergic symptoms that were suggestive of a mast cell disorder. And so we re-imaged her looking at this. And so again, the aorta is the big thick line in the middle. The top artery that's coming off and going to the right that has that narrowing and then that dilation after it is her celiac artery. So she still has high flow velocities there. But when she's gone back to the surgeons, they've stented it, they've dilated it, it's never changed anything. We did a 3D reconstruction, we can see this. But then, now that she has all these other symptoms, all these other things going on, how could this be just a vascular problem? And so we started to think about it differently. And really, when I talk to some of my colleagues about treating and diagnosing median arcuate ligament syndrome, they roll their eyes at me because they don't believe in it because the surgical outcomes are not consistent. So if this was a vascular problem and you actually alleviated the pressure on that artery, then you would expect nearly 100% of people to get better because you can measure that they should get better. Well, they don't. The surgical outcomes are somewhere between 30 and 70%. That suggests that maybe the diagnosis isn't quite right. So I sent her for autonomic testing, and it wasn't entirely consistent with it. So she had a heart rate increase with a 70-degree head-up tilt of 26 beats per minute, and in her age group, that should have been 40 if we wanted to get her a diagnosis of postural orthostatic tachycardia syndrome. But she had ineffective esophageal motility, she had delayed gastric emptying, and she had delayed small bowel transit. So is this maybe dysfunction of the autonomic nervous system that we can't catch on tilt table testing, but we can check if we actually measure some of the other mechanisms of the autonomic nervous system? And I would suggest yes. So despite her surgery, which had been 3 years before I first met her, she's continued to decline. So this is just another gentleman. So he's 21 years old at the time I meet him. He already had a diagnosis of postural orthostatic tachycardia syndrome made at Vanderbilt many years earlier. But he actually was in college and doing well and then had to drop out. He came home and that's when he established care with me. And so he presented with worsening POT symptoms that we just could not get under control. He had weight loss and weakness. His BMI is around 12. He has significant trouble with eating. And so I started to think about maybe this is median arcuate ligament syndrome in this gentleman. And so this imaging does not show that vascular compression of the celiac artery. So he would not get a diagnosis of that if we thought this was a vascular problem. But I actually don't think it's a vascular problem. I think it's a neurological problem. And so I worked with my colleagues at the University of Utah to develop some imaging studies where we could actually try to get after this. And so this is a CTA protocol that we are using, and then this is an MRI protocol where we can actually visualize the celiac plexus and ganglia in relation to that ligament, because the ligament is lower riding in these patients, and it's actually interacting with the celiac plexus and the ganglia. And so if we do a CT-guided celiac plexus block using these anatomical landmarks, we have very high success rates of actually being able to completely alleviate people's pain. It's diagnostic, it only lasts a few hours, but they'll go out and eat like a cheeseburger, which they have not been able to eat in years, and they feel amazing. This to me suggests that we're on the right track as far as what the problem is, that this is not a vascular problem because a CT-guided celiac plexus block would not treat that. This is a neurological problem. And so I developed a hypothesis in this regard. So this is, you've got the abdominal aorta, you've got your two kidneys on the side, and then the yellow kind of spidery looking things are your celiac ganglia and the mesh network in between is the celiac plexus. And so in normal anatomy, that median arcuate ligament, which again is just a component of the diaphragm, is sitting above the origin of the celiac artery and not really interacting with the celiac plexus or the ganglia. In abnormal anatomy, it's actually a little bit more low-lying, so it's actually interacting with their ganglia. And so when they first present, they're presenting with abdominal pain. And so, because this is a localized inflammatory process that is just involving those few ganglia and that limited area of the plexus. But if we don't diagnose it because they don't have that vascular component, they're not going to get surgery, this is going to progress. And so you get more of the ganglia in that region involved. You have this, what I think is a spreading inflammatory cascade. You start to get more symptoms besides pain. You have symptoms related to, that would be suggestive of like a motility disorder. And then it spreads further. They start to have trouble with their bladder. And then they start to develop these symptoms that are suggestive of a systemic dysautonomia. And so again, if we look at the celiac ganglia and we think about this sort of inflammatory cascade, it can spread to a whole host of areas, including centrally, to actually include the central autonomic network. And so I started to think about this. What's this process? Like, what is this inflammatory process? I have tried and tried to treat these individuals with IVIG. They don't seem to get better. I've tried high-dose steroids. They don't seem to get better. So I think the immune process, this inflammatory process, is different than that. And so I've been reading and thinking about this, and there's been a new hypothesis published on complex regional pain syndrome and what are the drivers of that. So this is chronic pain that actually occurs after an injury, but it's a more classic injury, right? Like it's you fracture your ankle. But then your ankle heals, but you still have pain. And then that pain spreads to other joints, and then it spreads to the other leg, and then they end up with these dysautonomias. So this is some sort of process that's actually progressing, even though the injury itself has healed. And so there's type 1, which is no obvious nerve injury, and then there's type 2, where there is an obvious nerve injury, like in an ankle fracture or something like that. But these appear to be CNS-driven immune reactions. And so they've had like dendritic cells and microglia cells implicated in this immune process. And so when they've done functional MRIs of the brain of these individuals, they can actually show that there's increased activity within the basal ganglia. And they've actually looked at cytokine profiles in the cerebrospinal fluid, and these are abnormal, and these are sort of a pro-inflammatory state. And so I won't take you through the details of this whole thing, but this was published on this hypothesis of what's actually going on in complex regional pain syndrome and how do you still have that pain sensation and go on to develop this autonomic nervous system disorder in these individuals where the injury is healed. Is basically you have microglia activation, you have central activation, you have the vagus nerve like dysregulating kind of immune suppression. So then you have release of interleukins and cytokines and chemokines and B cells and T cells that are kind of going to the site of injury. So you have this sort of this feed-forward inflammatory cascade in these individuals. And so my hypothesis is that median arcuate ligament syndrome really is a neurological problem. So I call it neurologic or neurogenic median arcuate ligament syndrome to try and get after that. I think that when the systemic dysautonomia has occurred in these individuals, that this likely represents a case of complex regional pain syndrome where the site of the injury is actually that celiac plexus. So I think it's a nerve entrapment injury that occurs because of that low-lying ligament. I think it does need surgical decompression. But I also think that if we catch it early, we appropriately decompress it by recognizing this is not just a vascular problem, this is a neurological problem, that people will get better. However, if this has been present for years and the surgery wasn't done to address the neurological component of it, these people are going to progress despite surgery until we actually get after that inflammatory cascade. And I'm working on trying to figure out exactly what that inflammatory cascade is so I can pick the right therapies to treat that. So just in summary, I think gastroenterology actually has a lot more to offer besides giving your patients and you guys functional diagnoses. I think we have a lot more tools available to us so we can do testing that's meaningful to providers that are caring for you and your family. But I do think that multidisciplinary medicine is required for these complex patients, and I have a phenomenal team at the University of Utah. And you'll hear from a couple of them today. So Dr. Stacy Clardy in neuroimmunology. It's fabulous to have a colleague that knows so much about that aspect. I work with a clinical geneticist, Dr. Douglas Wall, and Dr. James Hemp, who you'll hear from, who will actually be talking about the microbiome and not his genetics work. But we're getting a lot more results from genetic testing because of the limitations of the reports that you get clinically. And then pathology, Dr. Maria Plotneva, who's agreed to do the mast cell counts for me when no one else in her department would because they roll their eyes and don't think this is a real disorder. And then radiology, Miriam Resvani, who's actually developed all the protocols and leads all my studies. And so they're integral parts of my team, which I couldn't function without. So thank you. I'll take any questions.